Good evening, ladies and gentlemen. I would like to welcome you to our free webinar, Platelet-Rich Fibrin and Evidence for Use in Dentistry, organized by Nuffield Academy. Tonight, we have the privilege of having our esteemed guest speaker, Dr. Samintharaj Kumar, to share his wisdom and insights on this topic. Dr. Kumar is the founder of Nuffield Dental Holdings and director for both MALO Dental and ZAGA Center in Singapore. A general dentist with a deep interest in surgical dentistry and implantology, he has used PRF since 2017. And without further ado, Dr. Kumar, please.
Thank you, Ken. Good evening, everybody. Let me just bring up the slides. Okay, so as Ken has mentioned, my name is Dr. Samintharaj Kumar. I am a practicing dental surgeon. I'm a general dental practitioner working at Nuffield Dental. I'm the CEO and the founder of Nuffield Dental. My interest in platelet-rich fibrin stems from chance. A few years ago, I had a patient who came down to see me in a clinic in Raffles Place. And at that point of time, the patient was actually on her way to Spain to actually find out how she could improve these things called cavitations that she's had in her jaws. She had wisdom teeth extraction done. And after the wisdom teeth had been removed, she still had persistent pain in the lower left quadrant. And she was actually planning to go to Spain to get this treated. And for whatever reason, she decided to come in to have a second opinion. And at that point of time, I was unable to help her. And as much as I already knew about PRF, having come from a background in maxillofacial surgery, I hadn't actually made it myself in a dental clinic, which means I didn't have a centrifuge. I didn't have the blood bottles. Obviously, I could draw blood, but I wasn't prepared in terms of the logistical support. I needed to prepare PRF or platelet-rich fibrin successfully. So on the basis that she had challenged me, she didn't issue a challenge, of course, but I was very keen to make sure I could treat the next patient that would come around to see me for this particular interesting aspect of dentistry, cavitation. Cavitation surgery, and that is how my interest in platelet-rich fibrin actually started. I did lots of reading, and of course, having done that reading now, I've decided to apply my knowledge of using platelet-rich fibrin extensively in my clinical practice in Singapore. And I look forward to sharing this knowledge that I have with all of you this evening. Right, so what's not covered today? I am not going to be talking about centrifugation protocols. There are many protocols available and many revised and modifications, which you can certainly look online, tons of videos as well, prepared by many dentists who have obviously modified Chokran's original PRF harvesting technique. So today I'm going to talk to you about PRF and what PRP is, the utilization of this biological component of blood in Singapore, and how you can use PRF in implant dentistry today. Obviously, I will be talking about the extensions of PRF, not just in implant dentistry, and also how you can use this in general dentistry, or for example, in perio, or even orthodontics. Now, I have prepared a very nice video at the end of this to show you how PRF is harvested and prepared. Now, for the vast majority of you, you would like to immediately start using this protocol in your clinical environment. Now, what is also not covered is venipuncture and the relevant clinical anatomy to ensure that you're successfully drawing blood at first go when you see a patient. For those of you who have not had the chance to work in hospital, or perhaps a maxillofacial rotation, perhaps it would be useful for you to find venipuncture courses. The next course that we have will be in 2 months' time. It will be held in the Dental Academy in Malaysia, Kuala Lumpur, and we will be teaching venipuncture for dentists around Southeast Asia. And of course, I will be able to share you with then the protocols I use for my PRF harvest protocol. So this is the inventor of PRF. This is Joseph Chokron. Joseph Chokron is credited with inventing or at least establishing platelet-rich fibrin as an excellent form of a biological substrate within the dental environment. Now, PRF is not just used in the dental environment, of course. It's used in plenty of surgical specialties, from general surgery to orthopedic surgery, the list goes on. But he has an interest in craniomaxillofacial and facial plastic surgery. And because of him, I think there are lots of patients who have benefited from the aspects of healing that platelet-rich fibrin offers to the patients. Now, let's look at the discoveries he has made over the last few years. Now, in 2001, he came up with PRF. 7 years later, he came up with leukocyte-rich platelet-rich fibrin, that is LPRF. And 5 years thereafter, there is advanced platelet-rich fibrin, APRF. And 1 year later, there is injectable platelet-rich fibrin. In 2017, standard PRF. And by 2019, sticky bone. Now, sticky bone actually has been used in dentistry for many, many years. But his protocols were aimed at simplifying it so that you will always be able to get the exact sort of consistency of platelet-rich fibrin in your clinical setting, with or without any form of additives to the mix. Here you are, starting off PRF. You want to take blood. You take the blood, you put it into the centrifuge, and then for some reason, you don't get PRF. So the question is, why? If it was just that straightforward, obviously everyone would be doing it. So I've also had many people chat with me and said that they had tried to do it in the department of oral maxillofacial surgery, but were unable to do so. And for various reasons we'll talk about in a while, to see how we can improve the success rate of ensuring you get a very nice, consistent amount of platelet-rich fibrin when you perform your centrifugation. Now let's look at blood. We have tons of blood in our body, of course, but what are we after here? We are truly after the growth factors, the platelets, and the most important component, a scaffold for all of this, which is the fibrin. Now, if you look at blood, what we don't want for platelet-rich fibrin is all the red blood cells. The red blood cells consists about 41%, and plasma is about 55% of the whole blood. And then you get this 4% of white blood cells and platelets. Now, that's exactly what we're after. We want a nice, thick clot of white blood cells, platelets, and fibrin. And this gives you what is known as platelet-rich fibrin. And this is where all the healing is in. When you take 10 cc's of blood and you centrifuge it for 10 minutes, you will get 3 sorts of layers. Right at the bottom, as you spin the blood tube, you'll get a red blood cell layer. This layer is of absolute no use to you, okay? So if you have tried, and many of us have tried, taking blood, mixing it with any form of bone grafts, and then trying to put it on a buccal onlay for example, an anterior buccal alveolar defect, and hope that that would actually improve the success rate of your bone graft. Unfortunately, all the red blood cells is just debris. So what you need actually is the fibrin, and you also need platelets, because platelets will help it clot quicker. And now you also have tons of growth factors within that PRF clot. So the top layer will be an acellular plasma layer. As you will see later on, my nurse will be putting in some forceps to go and draw out a platelet-rich fibrin layer, and that will come out as a thick snot-like clot for you to play with in your dental environment. So let's look at the components of platelet-rich fibrin, which I've already mentioned to you before. Principally, I told you that we need a scaffold for all of this to belong to, and that's the fibrin. Okay, so fibrin is inside And you'll find that this thick piece of cloth that's there, it's actually very, very sturdy, which means you can swing it around and it will stay in one piece if you've used the right centrifugation protocols. Inside the fibrin network, as far as possible, you want as little red blood cells as possible. As I told you before, red blood cells are just debris. They have no value to the area as to where you want to put your bone graft. Red blood cells obviously carry oxygen to the area, but they need to be in vessels or in capillaries in the area. With regards to platelets, of course, platelets will have a cascade of reactions which will allow the fibrin network to actually form. And for all these white blood cells, whether it's your B or T cells and stem cells with a conglomerate of growth factors, which will form the platelet-rich fibrin, which has a unique healing property, as I will show you. Let's look at the classifications of platelet-rich forms. Now, for those of you who are uninitiated into platelet-rich forms, there is either PRP, platelet-rich plasma, or there's platelet-rich fibrin. For today's purposes, we will not be talking about platelet-rich plasma. Platelet-rich plasma, as you will obviously fathom, has no fibrin in it. Whereas what we're going to be talking about today is platelet-rich fibrin. And today I'm going to be specifically talking to you about LPRF, which is leukocyte-rich and platelet-rich fibrin. There are other versions of PRF, as I alluded to you before. It does truly depend on the type of centrifugation protocol you use and preparation technique. But the simplest one that you can use, and this certainly is my workhorse, is LPRF. And this is what I will focus on in today's talk. I hope you've enjoyed what I'm saying so far. So now I'm going to be talking to you about in the Singaporean space, when you can choose PRF or PRP. Goes back to 2013, when there was a letter issued to all dental clinics talking about the use of platelet-rich plasma therapy in dental treatments. At the point of time, platelet-rich plasma was just referred to as PRP rather than PRF. But for the purposes of how the Ministry of Health of Singapore understands, or at least allows us to use PRF treatment, the only indications that you can use them for are fourfold. One, to mix it with bone grafts that you can use in sinus lifts. You can also add PRF to bone grafts to improve any form of osteo or bone augmentation in the maxillofacial region. You can also use PRF in periodontal defects where you want to improve or regain attachment. And of course, some of us who may want to soak free gingival grafts using with PRF to improve the stickiness and adherence of the free gingival graft to the recipient site. Now, of course, I would advise that if you have not used PRF before, please do partner with someone who has done it, or at least attend a course, because it just makes the whole process much more simplified. It's extremely easy to use, but it can be more predictable after you've had someone who's been advising you as to how, for example, myself, as to how I do in my clinical practice. Now, let's look at what PRF can be used in dental applications. Let's look at this example where you can see in A, you can see retained roots. Now, the retained roots have been removed in B, and then you can see a PRF membrane that's been used in C. And the PRF membrane obviously is held together by resolvable sutures. And you can see over a period of time that the periodontal periodontium actually is beautifully pink and there is no erythema around. For many of us who use bone grafts, we get frustrated because the frustration stems from a number of things. One, your graft material migrates. Two, your graft material extrudes. Three, whatever you've tried to keep in there has not, for some reason, it's decided to escape, and there's dehiscence. And these are sometimes in patients who have complex medical conditions And the one that is commonest, of course, and the bane of all implant dentists is smoking. I would hazard advice to you saying that PRF can actually improve the healing rate or capacity of that in a smoker. Now, if you look at someone who has had platelet-rich fibrin placed, PRF placed, you'll find that the healing is none other like for you who have used just a bone graft on its own and perhaps a collagen membrane. And you will always have the patient complaining of pain. And this is obviously because the body is now responding to this foreign body in whichever location you put it, and now then sends all the 5 signs of inflammation. Okay, and one of them obviously is calor, and of course dolor, and of course delay function. So you don't have people who want to go out because they've had surgery, so they want to go and rest. So there's pain, the body says go and rest. There's swelling, the body says don't go outside, people look at you. So that's the body's way of resting. However, with the use of PRF, you'll find that the healing is impeccable. And not only that, you'll find that there's beautiful sort of a pink response, a healthy non-erythematous response when you get healing after using PRF. As you can see in D, some of the PRF is obviously dissolved. That's the natural cause. And you can see in F and E that the residual site is beautiful in terms of how it looks clinically. And in this particular instance, where socket preservation has been done, you'll agree with me that it's very, very lovely anatomy there and perfect for someone who wants to place an implant in this location. Let's look at another case report which has been published in the literature, how we are worried about patients who have had bisphosphonate therapy, and we panic and say, what are we going to do? We want to reduce the rate of any form of osteoradionecrosis to the jaw. How can we improve the success rate? And of course, the typical answer for everyone would be to ensure the patient has good nutrition and to ensure the patient has a good sense of oral hygiene. Well, of course, that's all good. But aren't we looking for a magic drug that will improve the success rate of what you've put in a patient? In this case, you're taking a tooth out. So these are patients who are now very, very susceptible to osteoradionecrosis. And can you put a plaster, a handy plaster, or some sort of device or product which will help the patient heal such that they don't have any form of osteoradionecrosis, something which will allow wound healing naturally? Because if you're concerned, then of course you can look at PRF as an excellent way to ensure that your patients have the best chance to promote wound healing as naturally as possible without raising a huge flap, periosteal releasing incisions, or periosteal fanning for some of you. Now, if you get PRF, it's a very simple 10-minute procedure, and you'd have the benefits that I have seen in my patients with regards to how they respond clinically and how the wound and the site responds post-implant placement, post-bone graft placement. And mind you, we're talking about allografts. We're not talking about autografts. So we're talking about grafts which will elicit a foreign body reaction. But with the PRF seems to tame this rejection rate down. And my job obviously is to show you some cases later on where you will agree with me that PRF can be used to successfully ensure that your patients get the best chance at healing as possible, as far as possible. Now, I've already said to you before that PRF can be used in sinus lift treatment. Now, many of us who raise a bony window and take out our 1 mil syringes and try and compact as much bone as possible into the sinus. And you take an OPG after, you take an X-ray after that, and you find that, wow, the bone particles have gone absolutely everywhere. So how do people get lovely, lovely oval balls in the sinus, and how do they keep ensuring that this is consistently done? For some of us who are very, very good at using piezo surgery or specialized sinus kits, these kits help us to get a very, very nice sort of elevation of the bony window, and obviously the sinus membrane. But more than that, when you're able to introduce a bulk of bone into the sinus in one piece, literally when I say one piece, I mean something which is stuck together. This is called sticky bone. So when we place that into the sinus, you'll find that none of this bone graft that you have will come to pieces and go elsewhere. It'll stay in one location, and it's very, very easy to control. The frustration, of course, for all of us is that after we've done the sinus lift, many, many bone particles go everywhere, and your nurse will be sucking and sucking and using the suction until she's tired. So here we are using PRF in combination with deproteinized bovine bone and using it in the sinus, in this case, for bilateral sinus lifts. And the bottom, you can clearly see over here how well the bone has been compacted, and it's all sticking together very nicely. You don't get this, of course, if you just use bone graft without PRF. And you can look over here over a period of time how it actually will look like post-surgery. And here is obviously a membrane that's placed over the bone graft. So this is it's a PRF membrane as well. And that will provide a very, very lovely sort of seal over the bone grafts. And of course, you still can use a collagen membrane over this, but not necessary. Some cases I would use it, and we'll discuss as to why and when. Of course, one of the first photographs I showed is about socket preservation. You can place PRF in extraction sites, of course. Not only does it enable you to maintain the volume of post-extraction, you also are able to reduce hemorrhagic complications, which means it actually stops the bleeding. So in patients who've had, for example, on warfarin, any form of new generation antiplatelet therapy, you'll find that if you actually place PRF and use that in combination with your bone grafts, you'll find that the bleeding actually reduces much quicker. And certainly the healing is much better. And this particular set of articles, they actually say that there's lower bone resorption compared to implants inserted in non-preserved sockets. And of course, apart from just using PRF in the sinus, you can use it in the alveolar ridge. And in this instance, we're looking at a cleft, and a particular cleft can be actually treated without just using chips from the iliac bone, iliac crest. You can actually just use normal bone graft material. You can get it from Bios or whichever other company you fancy. And then you can use this with PRF because the whole thing becomes actually biological. Okay, so in this instance, you can actually use PRF to treat bony defects without using large amounts of good quality bone, of course, from the iliac crest of the calvarium. You can actually do without that, and you can actually try and use this with PRF to get a similar sort of result. Let's look at some of the applications that I have used myself in implant dentistry. I've played around a lot of this because I'm genuinely interested to give my patients the best outcome. If you have done implants for a significant amount of time, as many of you have, you will get patients who have failures. And when you have failures, the most important thing, of course, is to try and work out why it failed, because you don't want for that to happen again. And if there are ways to actually improve the success rate, you should try and employ them as far as possible. But of course, we don't want to make it to the point where you are literally using PRF for every single case and charging patients for this. It's up to you what you want to do in terms of the charges for PRF in implant dentistry for your patients. But I'll tell you now that there is a lot of scientific literature that talks about some of these things, which I'm going to talk and share with you about. Plenty of dentists have actually dipped implants in PRF. And why would they not? Because we've always had this problem where we want the implant surface to be as wetted as far as possible, wet it with blood. The moment the implant goes in, you want to see the blood rising up on the implant surface. In the instance of someone who's a smoker, where that doesn't happen, if you're using a cheaper implant system which doesn't have a very good implant surface, then you may wish to consider using PRF, because you literally get the PRF and then you dip your implant inside and then you put the implant in. Now, obviously, this adds a lot of time to the whole process. And you actually have to time and plan so that the patient has a very nice experience from the point they enter your clinic to the point they leave. Because now you're introducing a lot more. You're introducing venipuncture. You're removing blood. You're then mixing the blood. You're then waiting for the PRF to set. And then, of course, you then take your PRF and you coat your implant with it and you place it. So these procedures will take time if you have not had any form of training or any form of advice as to how you can plan this so that it's done very, very quickly and very efficiently. Plenty of PRF can be used as a plaster in the mouth. So you have an open wound. You don't want to raise a flap for whatever reason. Take a bit of blood. You can actually put the PRF on. It's a fantastic plaster. You can use it for rich preservation. In this instance over here, you can see that PRF has literally been taken and just squeezed into the extraction site. And you can put some sutures over there as well. Now, sometimes you get some patients where you really don't want anything to go wrong for some reason, okay? When I say this, every single patient should be treated the same way, of course. But sometimes we get particularly worried about certain patients for whatever reason. In such patients, I'm sure we do anything to ensure that it's successful. You may wish to consider adding PRF around the vicinity of an immediate implant. As most of you know, immediate implants are successful. Many years ago, people would scoff and say that immediate implants are not good. We now know that the success rate of immediate implants can be high as 96 to 98%, depending on the study that you read online. Now, the success of the immediate implants is truly dependent on the operator and, of course, the patient factors. So if you have very good patient factors, even a poor operator can actually get success. But the difficulty comes in, of course, with patients who have compromised bone vascularity, bad habits, medical factors such as diabetes or poorly controlled diabetes, type 2 diabetes, which actually give them very poor healing outcomes. But in this instance where you would have the use of PRF, you're improving as much as possible the healing capacity when someone who already has a poorly vascular anterior buccal segment, post-smoking, of course, or someone, for example, after you've extracted the tooth and you're staring into the socket and you're wondering where and why is it not bleeding? Where's all that blood going? You whip out your venipuncture kit, you take some blood, you make some PRF and surround the implant with the PRF clot. For some of us who are interested in treating patients and doing guided bone regeneration, with lots of infra-bony defects, you can use PRF as per the MOH guidelines in Singapore to place PRF and to allow the area to basically form a very nice clot of white blood cells. Obviously, your patient has to have good debridement before doing this, of course. This is not a magic show, as you can obviously appreciate. And as I've mentioned to you before, you can use this in sinus lifts, very commonly used in sinus lift. I love using PRF with my bone graft material for sinuses, and it gives me excellent sort of outcomes. And once again, you can use this as a plaster anywhere. If you wish to use a bit of PRF over your soft tissue, it'll actually completely block off all those small little gaps in between your flap. And this will improve your healing rates. And one thing to note, of course, after PRF is used, when you see the patient in a week's time or 2 weeks' time, you'll find that there isn't the same sort of erythema that you would expect to see otherwise. Now, in this particular instance, I've used a product called OsteoMesh, and a lovely sort of bone substitute. And you can actually use this in combination with the PRF and any form of allograft you wish. In this instance, I use something called Osteon. And you can see severe alveolar buccal bone loss here. I've placed the bone graft plus PRF. So essentially made PRF using patients' blood and then made sticky bone using all of this together. I've put it on buccally to somewhat give a nice contour to that whole buccal wall defect. And I've then put the OsteoMesh on top of this and sutured. And you can see the volume that I've actually gained. Pre-operatively, this is a sort of a defect, and post-operatively, you can see based on the CT scan, very, very good also integration of this alloplastic substance I've used, and And of course, in this instance, one of the things that osteomesh is fantastic for, of course, is to restore the soft tissue anatomy. And that is one of the reasons why I still persist in using osteomesh in combination with both PRF and particulate bone. Now, what happens in the atrophic maxilla? I mean, we treat patients who've got atrophic maxilla. Of course, we can graft them and then come back to surgery after 4 to 6 months. But how about a case where you have very, very severe resorptive ridges? And you can see here, a patient over here, and that, of course, is the nose up there. And you can see a lot of buccal threads the threads are shown buccally, and you can see not even bone at the apex. What actually happens to these sort of patients when we use both a PRF and bone particle, a sandwich sort of technique? This is the main problem that we face in all-on-4 surgery. You get lots of resorption in the buccal region. But for some reason, if you place your implants palatally, you don't have this problem. And the reason for that is because palatally, the gingiva is so thick, it affords great protection of the implant. Anteriorly, as the patient undergoes aging, the patient loses yet more bone. So you have to consider how you'd actually reconstruct these defects. For me, I tend to use both PRF in combination with bone grafts and, of course, an osteomesh. Now, there would be some instances where I would just dip the osteomesh in PRF, and that would be all that I need, because PRF is also osteogenic and has osteogenic potential. So you want to reduce as much foreign bodies as far as possible. You want everything to disappear into carbon dioxide and water at some point. And because it's going to be a volume of which the patient's own bone should replace. And of course, as I said to you earlier before, with regards to any form of patient with osteoradial necrosis, there are many ways to treat patients with osteoradial necrosis. Fortunately, I have been very fortunate to treat such patients in England when I was working in maxillofacial departments. And of course, by and large, the principal modality was a good debridement. And we obviously had sent them to dives in hyperbaric chambers and stuff like that to improve the success rates. But here you have another therapy of bringing in white blood cells and tons of growth factors right in the area where the patient's having problems with bone healing. So I would strongly endeavor for those who have patients who have got BRONJ, not to treat them in the dental clinic setting, private dental clinic setting, but perhaps sending them to our maxillofacial colleagues or a hospital where the patients will get a much better sort of level of care. And certainly they would be able to monitor the patients over a longer period of time. But here is what I would think that PRF might be a good option for such patients. Now, for patients, and so in the land of orthodontics, everyone wants to know how you can actually improve the rate at which teeth are being moved. And there's now lots of data going about how we can use injectable PRF. So your PRF, which sets, as you know, we want to do something, a modification to the centrifugation protocol. And now you use that same PRF, but an injectable version, and then it will stay and set in that position. In this instance, you can see they've basically decorticated between the teeth to try and improve the speed at which teeth move. Now, for some of us, we wouldn't want to put our patients through this, but once again, these are all about understanding bone biology and seeing how far we can push science. And you can see over here, not real much was done in terms of damage to the patient. The patients heal beautifully, of course. But where else you can use PRF, of course, for patients, if you do not have sufficient gingiva anteriorly, of course, as you expand the arch, but we should consider a free gingival graft, in which case a PRF added to a free gingival graft will be very, very useful for you to secure and ensure that it sticks to the bed. And for many of us who are keen to treat patients who come in with tons of pockets, there are tons of studies available that show that you can actually inject PRF into clean infracrustal bone defects, and it actually improves pocket depth improvement in creating obviously the long junction epithelium that we always want to ensure that the area actually is filled up with the true bone after a period of 6 months. Here you see in this diagram a patient who has had, so this is basically a test that shows how PRF is used in osteotomies. And you can see here how the implant is basically rinsed with the PRF or the serum that you get from the top. So it's a bit of PRP and PRF, and to allow some of it to actually set on the implant surface before actually placing it into the osteotomy for the implant. Now, I've already been speaking for a while, and I mentioned right from the beginning about why I got interested in PRF. And here is truly what happened. After that patient went away, about 3 months later, there was yet another patient that came to me and said that she had cavitations. For some reason, it kept happening and happening again and again. So obviously by then I had went and gotten myself trained, and I had the centrifuge. And there I was, I would then open up the area of where the wisdom tooth had been removed, and I'll see a huge defect there, a huge hole there, which would not be seen easily on an OPG. So that's a cavitation. And how do you treat cavitations? You're actually meant to curette. And in certain countries, obviously, they allow dentists to use ozone to clean the area as far as possible to remove any form of chronic bacterial colonization of the cavitation. Followed by which, it's always advised that they obturate or fill up the defect, not just blood, of course, as I've told you, blood is full of red blood cells, but instead to use pure PRF. And this is exactly what we did. We removed the cavitation. We decorticated the insides of the cavitation, and that large cavity was then thereafter filled with PRF and tension-free closure on top of that. Now let's look at the armamentarium that you will need to perform PRF harvest successfully in your clinic. On the top left-hand side, you will see that that's the PRF kit. Should you wish to buy the PRF kit in Singapore, it's a very simple phone call to Sneha. Sneha is working in one of the companies that I'm related to, in Medident, and you'll be able to get a number at the end of this lecture. And it's a very, very simple kit, but it gives you all the instruments that you would need to do a number of things. Firstly, you need containers to ensure that you collect the clot. And collect the clot, you can actually do a number of things with the clot. You can make sticky bone. You can make sticky bone by ensuring that the clot is mixed almost immediately once it comes out of the centrifuge with any form of bone graft substitute that you like. Then the surface that this kit has, of course, enables you to place the PRF clot on top of this and allow you to flatten using the lid. Now the lid has a 1 millimeter sort of thickness between the inside of this lid and the platform, which means your PRF clot here is now transformed into a 1 millimeter membrane. Now, of course, you don't really need to be drawing lots of blood to do these procedures. Now, I typically draw anything from 18 to 20 mils. I know some of my friends who draw more than that for bigger sort of defects, and some who actually draw a lot of blood just because they want more membranes. These membranes are fantastic. In fact, they can become very, very thick. And in fact, you can actually keep them up to 7 days, okay? If it's done correctly. In B, you'll see the centrifuges. Centrifuges are easy to obtain, but the problem is that not every centrifuge is the same. With the centrifuge comes the position as to how the blood tube is tilted and the G-force that the blood actually experiences during the centrifugation cycle. So one may think that all centrifuges are the same. I'll tell you they're not, and it's very, very important you get a very simple system because a centrifuge can be used for a very, very long time. Once again, if you need to get a centrifuge, please kindly contact Sneha from Medident International. In C, you will see that blood has been taken using a vacutainer system. Now you can use a vacutainer system with a red blood tube to draw blood. And today, whilst we're not covering the anatomy related to venipuncture, certainly it's a very simple procedure to do. And thereafter, after the blood is centrifuged, this is exactly how you expect to see the PRF clot. And that's the PRF clot on this stage of the Prf kit. And there are tons of other instruments that are very, very useful in terms of either packing bone graft or sticky bone into an alveolar defect, or for example, cutting off and trimming. These are very sharp scissors, of course. And I would think that if you have a PRF kit, you would have everything in the same place without looking for other instruments to prepare your PRF, whatever procedure you're going to do with PRF. So now, a video. So you've taken the blood, spun it, and this is what you look at once it comes out, okay? This is my nurse. She's removing the top of the red blood tube. Now the PRF is actually in the middle, right? You get an acellular layer on top of this, and that's her drawing out the PRF. This is one technique of doing it. She applies suction and she removes the PRF. That's the PRF with the clot at the bottom. Here, that's me cutting off the clot, putting it into some, in this case, we've used Osteon. And then using the kit that you can see, this is the actual kit that you can get. You then mix the PRF with the graft. And you have to be very patient in doing this. There's no reason to rush this, because you really want to cut up that PRF or squish that PRF as much as possible to ensure a very nice uniform mix as far as possible. Sometimes it's not easy to do. Sometimes it's much easier to do. It really depends on the patient's sort of blood and their hydration status, of course. We tend to tilt this whole bowl, and you can see over here, this is literally sticky bone. That's me squeezing the sticky bone and showing you that even though I've broken it up into two, I can put it back together. I can actually pick it up using the forceps, and you can see it all, the whole thing sticks together. It's one congealed, sticky mess. Now, of course, I said to you before, you can make Prf membranes. So it's the same procedure. Take out the PRF. One fat globule of PRF there. And then so in this instance now, I would like to also make a small PRF plug. Plugs are very useful, of course, because they can be placed and compacted into extraction sites. So the Prf kit actually comes with small little wells to make Prf plugs. Okay, and then there you go. The lid goes on top of this, and then you're going to get your 1 millimeter sort of thickness membrane. So that's the consistency of the plug. And of course, it really looks like nose snot. And here you go, your Prf membranes, which you can stretch, you can fold over, you can fold a few times, or you can stick the whole lot together and make a Prf plug. You see how strong that membrane is. So ladies and gentlemen, I would like to thank you for the attention you've given me this evening. And it's been my pleasure to share with you the little insight that I have about how to make platelet-rich fibrin successfully in the confines of your dental clinics. That particular incident that prompted me to learn about cavitations and how to manage them also allowed me to learn techniques as to how I would then be able to rehabilitate complex patients with lots of bone loss, with patients who would have, for example, after wisdom tooth surgery, wanted better healing. These are the techniques you can use to actually improve the healing capacity of your own patients. As I mentioned to you before, we are always fighting with biology inside the mouth, whether it's poor oral hygiene or patient systemic factors. PRF can be used to improve the success rates of which you, especially in the realms of implant dentistry, it's an extremely useful tool. I would say to get started, it's important to do lots of reading. A course is coming up, as I said, at the Dental Academy in Kuala Lumpur. You can actually go to the Dental Academy website or follow at the Nuffield Dental Academy website for more information about training opportunities. With regards to PRF equipment inquiries, please look for Sneha, and Sneha will be able to signpost you to the relevant sort of places where you can get these things. And certainly the PRF kits is a must-have, else it's quite difficult to do the preparation that is required to get good quality membranes and certainly good quality sort of platelet plugs. I'm very happy to take questions, of course, but as I said to you before, I will not be sharing any form of centrifugation protocols or anatomy related to venipuncture, because that'll be done at the course. So with that, thank you, Ken, for this opportunity, and thanks for hosting me. I'll answer questions now.
Dr. Kumar, there's actually a question in the board. Doctor, when to use sticky bone and when to use only Prf membranes plugs?
Sorry, say the question again, please.
Okay, let me repeat that. Doctor, when to use sticky bone and when to use only Prf membranes or plugs?
Wow, this question is actually we can talk about this for a long time. Sticky bone is basically used in any form of alveolar defect, or in this case, we've seen in sinus surgery. If you want to do any form of sinus floor augmentation, you want to use sticky bone because it stays in the same place. Now, in the instance where you want, for example, a thicker connective tissue, or for example, to eliminate some infrabony defects, you may want to use either a PRF plug, as you've seen just now, or you can actually take the PRF membrane itself and just push the whole lot into the infrabony defect in order for you to actually eliminate that. In my particular use of PRF, I love using PRF in the instance of alveolar defects, because I just find that it's that much easier to handle. There's less bone extrusion, and certainly when I use sticky bone, I do sometimes tend to use a collagen membrane on top of this, because the perennial problem we face as implant surgeons is that the bone graft tends to extrude no matter what we do. And half the reason is because we put too much. So there'll be the reasons and how I will indicate the various uses of using a PRF, sticky bone, and certainly a PRF plug. Any further questions? No questions. With that, I'd like to thank everyone for attending this evening's webinar. Thank you, and see you soon.